thank the ANBAI and Dr. Srinath for giving me this opportunity to be with you for about 40 to 50 minutes to deal with renal function, physiology, especially applied physiology, and I will just touch upon AKI and CKD. The AKI and CKD will be dealt up with separately in greater detail. So I'll be only touching upon the AKI and the CKD. AKI is acute kidney injury and CKD is chronic kidney disease. You must be aware of that. So in the next 40 minutes or so, we will go through the applied physiology, basically how the kidney functions and how the pathological changes occur, which are going to affect our management when we take care of patients who have renal disease, who present to us in the nephrology units or in the critical care units or in the anesthetizing operating rooms. The kidneys, as you all aware, are bean-shaped organs situated in the abdomen retroperitoneally on either side. Each kidney is about 4 to 5 centimeters, 4 to 5 inches long, and it is roughly the size of one's fist. The basic function, as is understood by most people, is excretion of the waste products. So the basic function is the kidneys are important to excrete the waste products of metabolism. The body is trying to get rid of things which are not needed by the body. But in addition, there are several other important functions which are not known as widely. The important functions are maintenance of the fluid balance and intravascular status. So the kidneys play a very important role in maintaining the intravascular volume. They also are important in maintaining the electrolyte concentration of the blood intracellularly and extracellularly. They are important in acid-base balance. They're extremely important in vitamin D metabolism and hence the bone metabolism. And lastly, but not the least, they secrete hormones which are vital in the function of the metabolic function. These hormones are renin, prostaglandins, and erythropoietin. Though they are not a big organ in size, they receive about 25% of the cardiac output. If the cardiac output is 5 liters per minute, every minute 1.2 liters of blood is going through the kidneys, which means that for every minute, one cardiac output is going through the kidneys. So this is the functional capacity of the kidney. It is filtering the blood. The whole of the blood is filtered in about 4 minutes. And the blood passes through the kidney several times a day to keep the internal milieu in the normal range. The kidney contains what are called as tiny factories. These are called the nephron. These are silently working units, functional unit of the kidney. Each nephron has a glomerulus and a tubule, and there are about 1 million nephrons in each of the kidney. These are silently working in the kidney to keep the body in shape with all the functions going on perfectly. The difference between kidney and the heart is that if the heart suffers ischemia, you get chest pain, whereas in the kidney, you don't get any pain for the first till about 50% of the organ is damaged. There may be no symptoms whatsoever till 50% of the nephrons are dysfunctional or lost. So the kidneys are silent workers. They always work without making noise, and that's how it's very important to realize that these kidneys may fail without your knowledge, and hence we need to know a lot more about it so that we can be able to detect the kidney dysfunction early so that the treatment or the preventive aspects can be taken care as soon as it's possible. This slide shows the anatomic relationship of the nephron and the renal vasculature. Here, the renal arteries, when they enter the kidney, they divide into interlobar arteries. This red structure is the interlobar arteries, which becomes the arcuate artery. which divides again into interlobar arteries. These are the interlobar arteries. And from each of the interlobar arteries, lobular arteries, this is the interlobar artery, this is the interlobular artery. From each of the interlobular artery, you get the afferent arteriole, which form the glomerular trough, which is present inside the glomerulus. The afferent arteriole goes and forms the glomerular trough, and from there you get the efferent arteriole. The yellow structures are the venous drainage channels within the kidney. This is a diagrammatic representation. And the efferent arteriole, which is juxtaglomerular, they become what are called the vasa recta, which are closely applied to the long loops of Henle. And these are responsible for maintaining hyperosmotic interstitium, which is required for concentrating the urine. And on the right hand side, you see two nephrons. This is the nephron, which is a short loop of Henle, and the other one is a long loop of Henle. This is the juxtaglomerular nephron, which goes inside the medulla and is responsible for maintaining the internal milieu. Coming to the renal distribution of blood flow, you have two components of the kidney, the cortex and medulla, and the cortex gets 94% of the blood flow. Most of the blood flow goes to the renal cortex, and medulla gets only a paltry 6%. And this is the reason why the medulla is extremely prone to hypoxia and ischemia. So if you look at the blood flow in terms of ml per minute per gram, it is 5 ml here per cortex, and it's only 0.03 ml per minute per gram. And if you look at the PO2 values in the cortex, it's 50 millimeters of mercury, whereas in the medulla it is 8 millimeters. It is very low. And if you look at the oxygen extraction ratio, that is the ratio between the oxygen supplied and oxygen taken up, the ratio is almost 80% in medulla, whereas it's only less than 20%. So whatever oxygen is there is taken up in the medulla, and hence if the oxygen is already low, if the supply of oxygen is low, it becomes ischemic very rapidly. The next slide shows the juxtaglomerular apparatus. When you look at the glomerulus, it consists of 5 distinct components. We have the glomerular capillary endothelium. This is the afferent arteriole, and this is the efferent arteriole. And you have the glomerular tuft of arterioles here. And this at the glomerular membrane, you have the capillary endothelium, which is in touch with the basement membrane of the glomerular capsule. And then you have the visceral epithelium of the Bowman's capsule, and then you have the parietal epithelium. So we have actually 5 structures here. We have the capillary endothelium, basement membrane, then the Bowman capsules, visceral epithelium, and then the parietal epithelium, and then there are mesangial cells. The juxtaglomerular apparatus is a remarkable integration of tubular and tubular structure and function. This is a portion of the thick ascending limb of the loop of Henle, which has specialized cells which have chemoreceptors in them, and they're sensitive to the ions, especially sodium, and they respond to the sodium changes within the tubule, which is the tubule here, and the cells of the capillary endothelium are baroreceptor in nature. They are sensitive to pressure changes. Here, these are sensitive to chemical. These are chemoreceptors which are responsive to chemical changes, whereas the endothelium is responsive to pressure changes. And hence, if they fall in the pressure, they respond and cause activity or release of renin, which is responsible for secretion of aldosterone, which in turn causes vasoconstriction and mineralocorticoid activity, leading to conservation of the fluid. The next point we need to know is that there's a tubuloglomerular feedback. That means that the functions of the tubules and the glomerule are interconnected by a feedback mechanism. Whenever there is increased sodium chloride concentration in the tubular fluid in the loop of the Henle, the signal is generated by the macula densa, as we said that the cells in the macula densa are chemoreceptor sensitive, and hence they cause afferent arteriolar constriction and reduce the glomerular filtration rate and maintain the fluid and electrolyte concentration of the body fluids, especially the blood, within a narrow range, which is necessary for functioning of the tissues. Whenever there is a fall in the blood pressure, the glomerular filtration reduces, glomerular filtration reduces, and there is decreased sodium chloride concentration, which increases the renin levels, which acts upon the angiotensinogen to convert angiotensinogen to angiotensin 1, which is converted to angiotensin 2 by the angiotensin converting enzyme. This angiotensin 2 has a powerful arterial vascular resistance, a vasoconstrictive effect causing increase in the arterial resistance, and hence the glomerular hydrostatic pressure is maintained within the requirement for the body. This shows that the structure and functional relationships in the renal tubule, as you know, that the renal tubule basically contains the glomerulus, the proximal tubule, the loop of Henle, and the ascending loop of Henle, and then the collecting tube. Here, the metabolically most active parts of this tubule are the proximal tubule, the ascending limb, and the distal tube, cells in the proximal distal tube. These cells have a lot of mitochondria, and there are constantly high degree of activities going on, which is responsible for the maintenance of ionic balance. Some of them generate energy to be able to do the ionic transfers against a concentration gradient. If you look at the forces which are causing filtration across the glomerular capillaries, we have the glomerular hydrostatic pressure, which is about 60 millimeters of mercury, which is aiding filtration. And you have the Bowman's capsule pressure and the glomerular colloid oncotic pressure, which are opposing filtration. And these um, opposing forces and the forward forces balance out and cause the filtration of the blood, leading to the formation of tubular fluid, which undergoes after filtration two other processes called as reabsorption and secretion, which leads to the final formation of urine as it reaches the distal collecting ductule. So we have the arterioles, afferent arteriole and efferent arteriole, which are responsible for maintenance of the vascular tone and hence the filtration pressure. If the efferent arteriole is constricted, there will be more of filtration, whereas if afferent arteriole is constricted, there is decreased filtration for obvious reasons. So the same thing is depicted in this diagram. The filtration depends upon the glomerular filtration pressure, which is a difference between the pressure in the afferent arteriole and efferent arteriole. And in cases where we have low levels of adrenaline given, the efferent arteriole is constricted, whereas the afferent arteriole is dilated, and hence the glomerular filtration is reduced. But with higher doses of sympathetic activity or infusion of exogenous catecholamines, the afferent arteriole and the efferent arteriole both constrict and the glomerular filtration rate drops. And this is what happens when the patients have hypovolemia or in a shock state, where the body is trying to conserve the fluid. There is afferent arteriolar and efferent arterial constriction leading to fall in the glomerular filtration rate. Glomerular filtration pressure is reduced and urine formation is reduced. Patient develops oliguria. But in the initial stages, the kidneys are actually helping the body by maintaining the volume status. Suppose patient is losing blood or patient is losing fluid as a result of vomiting or diarrhea, or any other reason, the kidneys are protecting the body. Actually, it's not exactly renal failure, but as a renal success in terms of maintaining the body fluid status by maintaining body volume. But if this is progressive and not treated in time, then you have the acute renal failure and tubular necrosis, which can set in. If you look at the effect of changes in the afferent arterial resistance and efferent arterial resistance on the glomerular filtration rate, with the efferent arterial resistance, actually glomerular filtration rate rises, but with afferent arterial resistance is increased, both glomerular filtration rate and renal blood flow decrease. Coming to the mechanism of tubular secretion and reabsorption, we said the nephron has three major functions. One is the filtration, second is the secretion, and third is the reabsorption. All these three processes are vital for the final formation of the urine, which is excreted from the body. And then we have dealt with shortly with the filtration function. We'll go on to this secretion and reabsorption. In this schematic diagram, we have this is the tubular lumen, this is the tubular cells, and these cells has two types of membranes. Actually, this on the lumen of the tubule, we have what is called the apical cell membrane. On to the interstitial side, we have the basolateral cell membrane, and this is the interstitium, and this is the blood. And the major mechanism which is important in this is the sodium potassium ATP pump, which is present on the basolateral membrane, which is responsible for pumping out of sodium into the interstitium against the concentration gradient, which in turn causes shift of sodium from the tubular fluids into the cellular compartment, which is also aided by the exchange of hydrogen ions, which is occurring in the um, uh, apical cell membrane. The sodium exchange is occurring in exchange with hydrogen ions. So the body is getting rid of hydrogen ions, which is responsible for causing acidosis. So renal function here is extremely important to maintain the hydrogen ion concentration within a narrow limit, leading to a plasma or blood concentration of hydrogen ion uh, uh, between 36 to 44 nanomoles per liter. And this hydrogen ion is produced as a result of reaction of carbon dioxide with water in the presence of carbonic anhydrase, and the bicarbonate produced as a result is again shifted into the interstitium, and then the uh, acid produced in the body is gotten rid of in the kidney, and the bicarbonate is retained to maintain the acid-base balance of the body fluids and tissues. It is a very vital role, and hence we can understand that when kidney function is impaired, the hydrogen ion accumulate, and the patients have metabolic acidosis, which is to start with non-anion gap, then it becomes anion gap, and the lungs try to compensate for the acidosis by hyperventilation. Then coming to the oligemia, medulla, as we already said, medulla is intrinsically supplied less blood as compared to the cortex. You have the inner medulla, outer medulla, and the cortex. If you look at the blood flow to the cortex, it is 4.2 ml per minute per gram, whereas for the in the medulla, it is much less, about less than half, 1.9 ml per minute per gram. And the corresponding oxygen tensions are mentioned here is about 10 millimeters in the medulla. It's about 50 millimeters in the cortex. So this is again reiterating the point that the medulla is always under the risk of hypoxia and ischemia. And this does not happen normally, but when there is hypotension or hypoxia, the medulla suffers first, and then there is medullary ischemia, which is manifest in terms of renal function impairment. The concentration of urine occurs in the tubule, which is a very important function. The juxtamedullary nephrons have a long loops of Henle, which are associated with vasa recta. These are the vasa recta, and these are the long loops of Henle. And the movement of solutes or fluids occurs across the these tubules via the osmolar gradient or concentration gradient, but it also occurs against the concentration gradient, which is active process needing ATP energy. And as we look at the osmolality of the interstitial fluid, the osmolality varies anywhere from 1200 to 300 with the location or the position of the point where you are checking the osmolality in terms of the nephron. Here, the sodium is filtered or taken up into the interstitium. The sodium is actively transported from the fluid, luminal fluid in the tubules into the interstitium, and this bit is not permeable to water, and the concentration of the urine occurs in this portion, and also the urea is passively transfused. We look at the average concentration of different substances at different points in the tubular system. If this is 1.0 is taken as the concentration of the substance in the tubular fluid and the blood as equal to each other, as you go down the collecting tubule, the urea concentration increases, the creatinine concentration increases, para-aminohippuric acid, if you have gain, it increases, but the concentration of sodium, potassium, and chloride are almost same, but the glucose, proteins, amino acid drastically falls because of the reabsorption within the proximal tubule. So this is the mechanism how the important things are retained in the body and the waste products or the unimportant things are excreted by the kidney. And this is very important to understand how the kidney functions. The other important things we need to know about the kidney function is the renal autoregulation. What is autoregulation? Autoregulation is the intrinsic function of the kidney which keeps the blood flow constant within a particular range of the kidney. If the blood flow is varying from 80 millimeters of mercury mean arterial pressure to 180 millimeters of mean arterial pressure, the blood flow to the kidney is maintained constant by a process called autoregulation. But if the blood pressure, mean arterial pressure comes down to below 80 or below 60 or goes beyond 160 or 180 millimeters of mercury, the blood flow to the kidney becomes pressure dependent, which means that the blood flow decreases if there's hypotension, blood flow increases if there is gross hypertension. So this is important to understand because even hypertensive and diabetic individuals, these autoregulatory limits are elevated. And in these patients, we need to maintain the mean arterial pressure higher than usual to be able to achieve normal or the appropriate kidney function in that particular individual. So the mechanism of autoregulation is described or is described in either two of the mechanisms, myogenic theory and the tubular glomerular feedback mechanisms, which are responsible for renal autoregulation. Graphically represented, the renal autoregulation is shown here. We have the mean arterial blood pressure on the horizontal axis and the renal blood flow and the glomerular filtration rate on the vertical axis. So between the mean arterial pressures of 80 and 180 or 160, the renal blood flow is maintained constant. And similarly, the renal glomerular filtration rate is also maintained. But beyond these ranges, there is a decrease in the renal perfusion or increase in the renal perfusion depending upon increase or decrease respectively. And as I said, the kidneys get 1.2 liters of blood every minute. This is the renal blood flow, which is necessary for maintaining the filtration, absorption, and reabsorption and secretory functions of the kidney. So this is a summary of major activities, different parts of the renal tubule. We have the filtration occurring here. We have the renal tubular absorption and secretion, finally formation of the urine, and you have the active transport of the some of the important electrolytes, especially the sodium, reabsorption of water, and glucose and amino acid happening in the proximal tubule, and ultimately formation of the urine. And the concentration of the urine is influenced by the secretion of ADH depending upon the volume status of the patient. This is the changes in the osmolality of the tubular fluid as it passes through the different tubular segments. These are the different tubular segments: the proximal tubule, loop of Henle, distal tubule, collecting tubule, and finally the urine. The osmolality depends upon the effect of ADH, which in turn depends upon the volume status, and the response the positive pituitary gets in terms of the negative feedback mechanism. You have the normal plasma osmolarity of about 300, and it increases to about 1200, and the filtrate osmolarity increases to about 1200, and then comes down in the collecting tubule. Ultimate osmolarity can vary anywhere from 1200 to 300 depending upon the concentration of the urine, which again in turn depends upon the level of ADH, which is controlled by the body fluid maintenance mechanisms. Coming to how to assess the kidney function. Now we have talked about the physiology to a gross manner. We have the tubular filtration, we have the tubular reabsorption, the glomerular filtration, tubular reabsorption, tubular secretion, and then we have the renal autoregulation, and we have what are the factors which determine the glomerular filtration rate, and we need to know how to determine the kidney function. What are the markers of kidney function? This is given in a tabular form here, but we will just go into the main headings. We have the serum creatinine, which is included as a parameter in AKIN criteria, that is acute kidney injury criteria, rifle criteria, which stands for risk, injury, failure, loss of function, and end-stage renal failure criteria. And we have the kidney disease improving global outcome criteria. And we have the creatinine clearance, which can be derived from the Cockcroft-Gault estimating formula. And we have the glomerular filtration rate, which can be derived from the modified diet formula. And we have the urine volume, which is taken into consideration in all the three criteria which are used in the acute renal failure, AKIN criteria, rifle criteria, KDOQI criteria. And we have the BUN, that is the blood urea nitrogen, urine specific gravity, urine sodium, urine osmolarity, fractional excretion of sodium, and renal blood flow. All these parameters can be mentioned, but the practical parameters are basically the serum creatinine, which is the most important parameter of kidney function, which is clinically available, and it is the gold standard. Coming to each of the parameters one by one quickly, we have the urine output. The normal urine output is 0.5 to 1.5 ml per kg per hour. If the urine is less than 0.5 milligram per 0.5 ml per kg per hour, it qualifies to be called as oliguria. And the initial three stages of acute kidney injury are classed based on oliguria. If that is, if the urine output is less than 0.5 ml per kg per hour, it is a parameter which is taken into account when you classify patients in AKIN criteria. The second parameter is the blood urea nitrogen, which is produced by hepatic metabolism of ammonia. Urine is unchanged and does not bind to proteins, leading to rapid blood clearance, but it is reabsorbed by tubules, and one does not correlate directly with the glomerular filtration rate. This is in contrast with creatinine, which is filtered but not secreted nor absorbed, whereas blood urea nitrogen is filtered but is also absorbed. So it is not an accurate parameter for assessing the glomerular filtration rate. The normal blood urea nitrogen ranges from 5 to 10 milligram per deciliter. And the serum bun ratio to serum creatinine ratio normally is 10 to 1. And in an increase in this ratio to 20:1 or higher signifies pre-renal azotemia. The third parameter is the most important, creatinine, and then the fourth one is creatinine clearance. The creatinine is the endogenous product of creatinine phosphate metabolism in the muscle. It is produced as a result of muscle activity, protein intake, and depends upon the protein intake, muscle mass, and catabolism. In a steady state, the serum concentration of creatinine represents the creatinine generation rate, which depends upon the glomerular filtration rate, which in essence means that the glomerular filtration rate can be estimated or determined by determining the creatinine clearance, which is shown in the next slide. This is the renal creatinine clearance, the plasma creatinine level and glomerular filtration rate. The product is equivalent to the urine creatinine and urine volume, and hence if we know the plasma creatinine, urea creatinine, and the volume of urine produced, we can calculate the glomerular filtration rate for the simple reason that there is no reabsorption or secretion of the creatinine by the tubules. But is this the best parameter? It is the gold standard as of now, but it has some limitations. What are the limitations? The first limitation that the JAF reaction, which is used to determine creatinine levels, sometimes is prone to give false positive results due to naturally occurring chromogens. The second thing is N-acetylcysteine, an antioxidant used as a renoprotective agent, decreases serum creatinine levels, which may falsely imply the renal functions. The next point is that, as we said, that the serum creatinine is dependent upon the muscle activity and muscle mass, the protein intake, and the tissue catabolism. If you take a healthy person who is an athlete or who goes to the gym every day, does muscle activity, his muscles are active, and he consumes a lot of proteins, a creatinine value of 1.3 milligrams per cent for that individual may be normal, whereas the same 1.3 milligram per 1.3 milligram percent in a person who is cachectic, lying down in a bed, or who is inactive, may indicate early renal disease. So if you take a serum creatinine as a sole parameter, we may make errors in the judgment with regard to renal failure. Similarly, in patients who are acutely ill or in acute postoperative phase, because of the shifts in the body fluids and because of the hemodilution, the creatinine values may not accurately represent the onset of acute kidney injury in these patients. And the relationship between serum creatinine and GFR as measured by creatinine clearance is reciprocal and exponential. And the other important factor about creatinine is that the creatinine is a slow parameter to raise as a biomarker of kidney function. If there is kidney derangement, the creatinine rise occurs 24 hours later as compared to the onset of kidney dysfunction. So we come to know about the kidney dysfunction after 24 hours of onset of kidney injury, and hence the value of creatinine in acute situations is to be taken with a pinch of salt. Having said that, in a stable state condition, in a patient who is stable, serum creatinine is an excellent indicator of the status of the kidney function in a given scenario. So the creatinine clearance is more accurate in tracking rapid alterations in the glomerular filtration than serum creatinine alone. And this is derived by looking at the urine creatinine and the urine volume and the plasma creatinine, as we mentioned it in the previous slide. The assessment of glomerular filtration rate or the estimated glomerular filtration rate can be done using the sole value of creatinine depending upon the age, using the Court-Gault equation as is shown in the equation here. If you know the age and weight, and the serum creatinine value and sex of the individual, you can get a rough estimate of the glomerulofiltration rate. This is usually used in most of the biochemistry lab. When you get the serum creatinine, across that you get the estimated glomerulofiltration rate estimated, either using the um, Cockcroft-Gault equation or using the modification of diet in renal disease formula. This slide shows the relationship between serum creatinine, which is shown on the vertical axis, and the creatinine clearance. As the creatinine clearance comes down, the serum creatinine does not go up until the creatinine clearance is 50% reduced. Very important point to note. Unless there's a decrease in the kidney function or the creatinine clearance or the glomerular filtration rate by 50%, the serum creatinine does not start to increase. This is the inverse relationship. After this, there is a rapid increase in the, as the creatinine clearance comes down, there is a rapid escalation of the serum creatinine. Very important point to note. And this is also exhibited in the next slide where we have shown that there's an inverse logarithmic relationship between the serum creatinine on the vertical axis compared to the relative reduction in the glomerular filtration rate. The number of nephrons lost is shown in the bottom horizontal line. If you take 1 million nephrons in one kidney, as long as 50% of the nephrons are functional, there is no increase in the serum creatinine. Very important point to note. And only if 50% of the nephrons are dysfunctional, this serum creatinine starts to rise. This slide shows the relationship between 24-hour urine collection on the vertical axis and the creatinine clearance derived from the 2-hour collection. In the 2-hour collection and the 24 hours value, there is a good amount of correlation. That is 2-hour collection shown on the vertical axis and 22-hour collection shown on the horizontal axis. The creatinine clearance determined on by the volume of urine and the creatinine measured in the plasma and the urine, you get the creatinine clearance, and they have a reasonably good correlation. So you don't have to have always 24-hour collected urine sample to be able to get the creatinine clearance. 2-hour sample, 2-hour urine volume and urine creatinine compared to the plasma creatinine at that particular point of time suffices to determine the creatinine clearance in a given patient. That is the study which shows that 2-hour creatinine and 2-hour urine sample is enough to get the creatinine clearance. This shows the acute kidney injury network criteria. You have the two major parameters. One is the change in the serum creatinine and the urine output. If the serum creatinine is more than it raises by 0.3 milligrams, or it increases by 1.5 to 2 times the baseline value, and the urine your output is less than 0.5 ml per kg per hour for more than 6 hours, this is stage 1. In stage 2, the serum creatinine is 2 to 3 times the baseline, and the urine output is less than 0.5 ml per kg per hour for more 12 hours. And in the stage 3, the serum change in serum creatinine greater than 3 times the baseline, and absolute serum creatinine values for more than 4 milligram per deciliter. Here, urine output is less than 3 ml per kg per hour for more than 12 hours, constitutes stage 3 of acute kidney injury. The same thing is shown here, where they have integrated KDOQI criteria to show the acute kidney injury. This is the conceptual model of classification of kidney disease recently published in 2020. The factors associated with kidney injury, risk of kidney injury, and this is the stage of risk. This is the stage of damage, where this glomerular filtration rate has fallen down, and this is the stage of failure, and this is the stage of ultimate death. So here, if you see this triangle, as the glomerular filtration comes down, the kidney damage is increased. That is, reciprocally speaking, as the kidney damage increases, the glomerular filtration rate comes down, and the patient lands up with the end-stage kidney disease, kidney failure, and if not sorted out either by kidney transplantation or repeat dialysis, that is inevitable. So the kidney disease is classified as acute if the duration of disease is less than 3 months, or chronic if the disease is more than 3 months. And if the kidney injury has occurred, history is within 1 week, it is called acute kidney injury. Coming to the stages of chronic kidney disease, we go by the EGFR, that is estimated glomerular filtration rate, normally about 120 ml per kg per 1.73 meters square of body surface area. If the EGFR is less than 90, it is stage 1, 60 to 89 is stage 2, 30 to 59 is stage 3, 15 to 29 is stage 4, and less than 15 is kidney failure needing supportive therapy in forms of dialysis or kidney transplantation. Coming to adrenergic drugs, we have the dopamine, dopexamine, dopamine, phenoldiazepam, which are the dopaminergic drugs. They act on the dopaminergic A1, A2, beta, adrenergic beta 1, beta 2, and alpha 1 receptors. And both the receptors, whereas dopamine acts on the beta 1 and beta 2 receptors, and alpha is equivocal. So it does not act on the dopaminergic receptors. Dopexamine acts basically preferentially on the dopaminergic receptors and also beta 2 receptor, which means that it increases the heart rate. It is similar to isoprenaline when it comes to the effect of dopexamine on the heart rate, but the difference between isoprenaline and dopexamine is that isoprenaline does not have dopaminergic receptor stimulation, whereas dopexamine has both beta 2 receptor stimulation, beta adrenergic receptor stimulation, and the dopaminergic receptor stimulation. Phenol-dopam is purely dopaminergic receptor stimulator, which causes increase in the urine output, and it has been used as a vasodilator in patients who have hypertension in acute situations, which theoretically has protective effects because of its dopaminergic effect, but in clinical practice, not documented and not in the recommendation for treatment of acute renal failure. The neurohumoral regulation of renal function depends upon the balance between the vasoconstrictor and vasodilator mechanisms. Surgical stress, ischemia, sepsis, hypotension causes stimulation of vasoconstrictor systems, which are responsible for salt retention, whereas increase in the blood volume causes vasodilator systems, which causes stimulation of salt losing systems, and the delicate balance between these two mechanisms is responsible for regulation of which is regulated by the kidneys. With the vasoconstrictor system, renal blood flow is decreased, glomerular filtration is decreased, urine flow is decreased, sodium excretion is decreased, and the opposite occurs with vasodilator systems. This is the renin-angiotensin system. As we said in the earlier part of the talk, that the renin is secreted as a result of stimulation of the chemoreceptors and baroreceptors in the macular densa and the juxtaglomerular apparatus as a result of changes in the serum, changes in the tubular sodium concentration, and the pressure in the vasa recta. Angiotensinogen is produced by the liver cells, which is converted to angiotensin as a result of action of renin, which is produced by the juxtaglomerular apparatus, which is in turn converted to angiotensinogen 2, which is octapeptide by the action of angiotensin. This is the angiotensin converting enzyme where we have antihypertensive agents which either act on the receptors causing angiotensin receptor blockade, or they can be angiotensin converting enzyme receptor inhibitors. Angiotensin converting enzyme ACE inhibitors, I mean to say. And you have the angiotensin 3. Angiotensin is a powerful vasoconstrictor and it stimulates production of mineralocorticoids from the renal cortex on the top of the kidney and causes secretion of aldosterone, which in turn is responsible for um, preservation of the fluid. That is, it maintains or prevents the loss of sodium from the body and volume status is retained. So this is the action, how it acts on the distal tubular cytoplasm, attaches to a receptor, then migrates to the nucleus, where it induces the formation of a messenger RNA, which induces the synthesis of protein that enhances the permeability of the apical membrane to sodium and potassium, leading to reabsorption of sodium. And the second mechanism is responsible for the osmotic control is this elaboration of the arginine vasopressin, that is AVP, which are elaborated axonally and transported to the posterior over the pituitary gland from the hypothalamus, which in turn are responsible for water retention and maintenance of the serum osmolality. Coming to the pathological condition, this is a picture showing the acute injury patterns after cardiac surgical procedures. You have different surgical procedures on the um, horizontal axis and this degree of creatinine change expressed as percentage from the basal value on the vertical axis, and you have the less less invasive procedures. And as you progress, more and more invasive procedures cause greater increase in the average peak of the serum creatinine in the post-operative period. These are the serum creatinine values determined on a daily basis up to the post-operative day. These are the serial values, and this is the average peak value of the serum creatinine in that group. For example, this is the aortic port access surgery, mitral port access surgery. This is the mitral mid-sternotomy group. This is the off-pump CABG group. This is the CABG group on pump, and this is the valve heart surgery, aortic mid-sternotomy. This combined procedure, CABG plus valve procedure, this heart transplantation, this is the double lung heart transplantation. So from the left side to the right side as you progress, the severity or the magnitude of the surgery is increased. With that, there is increased incidence of acute kidney injury manifest as average increase in the severity of the acute kidney injury based on the measurements of the creatinine values, which are serially done from day 1 to day 6. One other important point I should mention here is that if you look at the serum creatinine on the day 1 after surgery, it's actually decreased. Please see, note that a patient might have had acute kidney injury, for example, in this case, but the serum creatinine has decreased on the day 1 because of the hemodilution and reduced hemoglobin, hemodilution, which is associated with reduced hematocrit in these patients and their acute fluid changes, and hence the creatinine value at this point of time is unable to predict the occurrence of acute kidney injury in a given patient. So we need to have a serial estimation of creatinine, and better is to have a biomarker which is response immediately or which increases immediately when the kidney injury is occurring, as and when the kidney injury is occurring. We'll go on to that in the next couple of slides. This is the comparison of the rifle, that is the risk, injury, failure, loss of function, end-stage renal failure, AKIN criteria, and KDOQI consensus criteria for acute kidney injury. We have the kidney disease improvement global outcome criteria on the uh, fourth column, AKIN criteria on the third column, rifle criteria on the second column, the class is mentioned on the first column, and the urine output criteria are mentioned in the last column. All of them use the serum creatinine and the urine output criteria, and then classify the severity of the kidney injury um, based on these criteria. On consensus criteria used in the recent process. These are the three common consensus criteria. And I guess that KDOQI criteria is most commonly used in most of the institutions and the recent literature and publications. The procedural and patient practice are related to production or causation of acute kidney injury in patients who undergo surgical procedures. The factors which influence the occurrence of acute kidney injury can be broadly classified into procedure related and these patient related. Patient related factors include comorbid conditions and patients preoperative renal function. The comorbid conditions essentially include diabetes mellitus, long-standing diabetes mellitus, presence of atherosclerotic disease, chronic hypertension. All these increase the risk of acute kidney injury in a given patient. Whereas these procedural factors include the occurrence of atheroembolism or myocardial dysfunction or systolic dysfunction, hepatic dysfunction, renal dysfunction. All these things will lead to the net in renal impairment, which is a direct bearing on the morbidity and mortality associated with post-operative renal dysfunction. If you take the occurrence of renal dysfunction based on the AKIN criteria, stage 1 recurrent, stage 1 or class 1 renal dysfunction occurs as much as 20 to 40% of patients undergoing cardiac surgical procedures, but most of them recover by the 5th day, and ultimately there's no damage. But in about 2 to 5% of the patients, especially 1 to 2% of the patients, the damage is so severe that they need renal replacement therapy. And out of these, 50% of the patients die. 50% of the patients who require renal replacement therapy following cardiac surgery suffer hospital mortality. And among the remaining 50%, 1/3 of the patients need dialysis on a long-term basis. So this is a serious problem in terms of hospital resource utilization, patient morbidity, mortality, and excessive costs used and inconvenience to cost to the patient party, patients and patient relations. And hence it is extremely vital to know how these factors work and lead to acute kidney injury. And the other factor which is not mentioned here is that it appears that there is genetic influence on this occurrence of acute kidney injury. For example, if you have two patients, one with genetic predisposition and without the other patient without genetic predisposition, if they are subject to the same stress level, the person who has genetic predisposition develops AKI, whereas the other one who did not have, he does not develop AKI. So these factors are being investigated, and we are involved in a large study with the ICMR group to detect the predictors of acute kidney injury in terms of genetic makeup of a given particular person. I also mentioned about the biomarkers. When we talked about creatinine, we said that it's a late biomarker. It takes 24 hours for it to increase. So we need to have something which is more quick. In this, we have had several biomarkers which the list as many as 20-25 biomarkers have been tested. But as of now, there is no clear-cut guidelines for the use of these biomarkers. The neutrophil gelatinase associated lipocarin, which is commonly referred to as NGAL, and you have the urinary interleukin 18 and the kidney injury molecule 1. And we have the insulin-like growth factor binding protein 7, tissue inhibitor of metalloproteinases. These two are called as nephrocheck, and there are investigations going on to detect if you have the baseline value and the post-operative value, if it could early predict the occurrence of renal insult, whereby you can institute therapeutic methods before serious damage occurs. These are the biomarkers which are available. And if you look at the increase in the biomarkers, this is the baseline value, and this is the upper limit of normal and the AKI threshold here. and the time after the surgery from 0 to 3 to 6 hours, 24 hours, 48 hours. If you look at the slide, NGAL is to immediately within 2 to 4 hours. This is the NGAL in patients who developed AKI. This is the NGAL, that is neutrophil gelatinase associated lipocalin. Neutrophil gelatinase associated lipocalin. But in patients who did not develop AKI, it did not cross the threshold value. Similarly, you look at the KIM, that is kidney injury molecule, it took about 24 hours to raise. If you look at the creatinine, it took longer than 24 hours. So NGAL has been projected as an early marker of renal dysfunction, but there are some certain issues with the estimation of NGAL in terms of terms of that in the is the fact that even neutrophils and inflammatory process can increase NGAL, and it is difficult to differentiate NGAL elevation because of kidney injury or the inflammatory process, and hence it has not been used routinely in the clinical practice, though it appears to be a significant contributor in detection of acute kidney injury. Coming to mechanism of renal sodium and volume regulation in response to decreased extracellular volume, the atrial filling is reduced, which causes decreased secretion of atrial natriuretic factor. In turn, reduces the glomerular filtration rate, and sodium is conserved both in terms of activation of macula densa, which increases the renin production, and also increased sympathetic tone, causing increased efferent arterial vasoconstriction, and increased sodium chloride reabsorption from the proximal tubule. And this slide showing metabolic clinical risk factors associated with post-operative kidney injury. We already referred to this. There may be preoperative acute kidney injury, intraoperative kidney injury, post-operative kidney injury, and the factors are mentioned on the right side of the slide. And with this, I would like to conclude saying that the kidneys are structures which are silently working. There are 1 million nephrons on in each of the kidneys. We have the glomerulus, the tubules, which are causing filtration, renal absorption, secretion, concentration of the urine, excretion of the waste products of metabolism. In addition, maintaining the vascular status, volume status of the patient, maintenance of the electrolyte balance, maintenance of the acid-base balance, and maintenance of bone metabolism, especially in terms of vitamin D, and erythropoietin secretion responsible for maintenance of hemoglobin concentration. All these are vital functions which, when deranged, will play a havoc in the patient's milieu interior, and there is acute dysfunction of the kidney. And as I said, the kidney dysfunction may not be realized till 50% of the dysfunction has set in. So it is vital to look at the parameters like biomarkers, which can tell us early in the disease process. And also we need to look at the genetic profile of the patient, which may predispose some of the patients to kidney injury rather than others, and try to limit the damage by either subjecting the patient to an alternative method of therapy, or providing the patient with a less invasive therapy, or taking preventive measures during the therapeutic procedures so that the kidney injury does not occur, or even if it occurs, it's of a milder magnitude which can easily revert back to normalcy after the injury or insult is taken away. With this, I would like to finish this talk, and I would like to thank you once again for this opportunity. And if there are any questions, I'll be happy to answer. Dr. Srinath, are you there? If there are any questions in the chat box, please let me know. Are there any questions? Is the chat box open? Are there any questions? I'll be happy to answer. So what we have done in the last 45 minutes is that we went through the physiological mechanisms. Basically, we looked at the kidney as a filter, which also does absorption, reabsorption and secretion. How the renal vascular mechanism works to maintain the intravascular volume and the control of blood pressure. And also we will look at the AKIN criteria, the KDOQI criteria, and what are the intraoperative factors which may predispose these patients to acute kidney injury. And we touched upon shortly, very briefly, about the biomarkers, which may be important, which may in future become standard of care of these patients, especially when they are undergoing high risk surgery or in the intensive care unit when they have when they are critically ill, to how to protect the kidney. All these things have to be kept in mind when we're dealing with patients who have renal disease or who do not have renal disease, but they are exposed to the renal insult. Thank you so much. Thank you for joining us.
Good evening, sir. It was an excellent highlighting opening for all, eye-opener for all of us. As usual, we enjoy your lectures, and that's a great one. Now the floor is open for any questions. Any questions, please? You can send me the questions.
I can see Dr. Datto and Chunki Datto in the screen.
No, that is
nice to see you. Thank you for joining. Thank you for joining. I hope you're all fine there.
Hello?
Yes, nice to see you.
You mentioned that 50% of nephron destroyed, then only creatinine level starts to increase.
Absolutely.
How a patient can realize that he is going to have kidney disorder?
This is very difficult. Actually, this is the difference between the kidney and the heart. When there is small ischemia, you get chest pain and you go to the doctor and you do the ECG and ST segment is elevated and you put a stent and that is done. Patient is saved. But here the kidney is very silent worker. It is like a servant at home. He silently works and takes all the insult, and only it comes critical point of 50% of the servant's mentality is damaged, that he says I can't work anymore, and he becomes depressed and he does less work unless the master does something about it. It is exactly same thing happening with the kidney. They are silent workers and they suffer damage without making any noise, and the symptoms where before the 50% of the kidney is destroyed are very subtle. So that's why in hypertensive individuals and in diabetic patients, regular follow-up in terms of checking up the urine for microalbuminuria and accurate control of the diabetes and hypertension is extremely mandatory to safeguard the kidney.
Thank you.
And in acute situation, we have to have some parameter like a biomarker which increases within 2 hours. A creatinine increases after 24 hours. So by the time the damage has occurred and you are detecting the kidney injury, it is too late. So if you can detect the kidney injury within 2 to 4 hours, you may realize that something is going wrong with the kidney and institute appropriate measures. And there are only 2 or 3 things which are definitive in protecting kidney. One is maintenance of volume status. Second is the maintenance of mean arterial pressure. The filtration depends upon the mean arterial pressure and the volume status. So if you maintain these two, these are the only protective agents. There are several drugs which have been postulated as renal protective agents, but none of them have come up to the recommendation level. There's no recommendation as far as renal protective agents are concerned, except that you avoid nephrotoxic drugs, you avoid aminoglycosides. You always see nephrologists saying avoid hypotension, which is true, but we always avoid hypotension. So these are the only things which are the definitive things which we can do to prevent kidney injury. Thank you, Dr. Dato. Thanks for joining.
Thank you. Thank you.
Thank you so much. Nice to see you on the screen. Thank you very much. If there are any questions, please tell me.
Any other questions, please?
There is one person who is trying to ask a question, is one George Thomas, but
Yes.
he will have to unmute, sir. George Thomas, sir, you will have to unmute. You are muted, sir, but you are not audible. We are unable to hear you, George, sir. Could you please speak up?
Madam, sir is in a meeting. Anything urgent? Any message, madam?
He's in a mute. If he's not able to unmute, he can write it on the chat box.
Yeah, I think looks like he is attending another call, Murli, sir. He's not.
Oh.
You occupied the bed?
So the ultimate message is take care of your kidneys. Do not ignore. Very, very important.
Okay.
Just like your heart, take care of your kidneys. That's my message. Thank you very much. See you sometime.
Thank you very much, sir. Thank you.
Thank you all. Thank you.
All
Thank
the
you.
best.
Thank
Thank you
you.
so much. Thank you.